Thanks for joining the People of Precision Health podcast, a series by Vibrant Health where we discuss the unique challenges of building human cohorts for health and clinical research. We talk with experts in population genomics and precision health to explore novel methods and real solutions for engaging the humans behind the data. Drawing on more than 10 years of pharmacy experience, Dr. Porscha Johnson, PharmD, certified genomic pharmacist, currently serves as the lead clinical oncology pharmacist for the Genomic Oncology Advisory Board at Northside Hospital, Atlanta. She specializes in cancer pharmacogenomics to understand how patient genetics informs their response to medications. Dr. Johnson oversees a large team of oncology pharmacists and focuses on educating her patients about therapeutic treatments for cancer. Her notable accolades include Pharmacist of the Year on behalf of the Atlanta Academy of Institutional Pharmacy and 40 Under 40 in Cancer, which is amazing, in 2022, so just recent, and Who's Who in America for Excellence in Oncology Pharmacy in 2023. In the coming years, Dr. Johnson intends to play an instrumental role in increasing the utilization of genomic testing and sequencing in cancer treatment across the United States. And I have no doubt that you are going to be at the absolute bleeding edge, to use, that's probably not a great phrase to use, but absolute forefront of innovation there. And I've really enjoyed our previous conversation. I can't wait to talk to you today. Thank you for joining us, Porscha. So let's get kicked off. As I said, I really enjoyed our earlier conversation. And when we spoke before, we talked about your experience and challenges you were seeing in your own family and circle, community, especially with the health system. And I think people talk about that in general terms, but I love that you really had specifics, and I want to revisit that.
Yeah, certainly. So when we spoke before, we kind of discussed my uncomfortable introduction to and personal investment in cancer. And so I've spent a majority of my life having this like love-hate relationship with oncology, having lost so many of my family members to some form of malignancy. My dad is a two-time prostate cancer survivor. And so it's really important for me to be a part of that solution because, when my aunts and uncles passed away from cancer, I was either in middle school or high school or even undergrad and was completely unfamiliar with the term cancer, but I was terrified of it because for me, oncology equaled I'm about to lose someone that I love. And so when my dad got diagnosed, it was such a here we go again moment. And it was, super frightening, but it gut wrenching reaction. But I was in between the first and second year of my fellowship and HEMONC and critical care. So I was like, okay, I don't know everything, but at least I'm a lot better situated in the knowledge base of it all rather than when I had family members who had passed away from cancer. So really going with him to Mayo Clinic and really understanding what it's like firsthand from a caregiver standpoint and dealing with oncology with an informed knowledge base versus a caregiver who has little to no oncology knowledge base whatsoever. It was truly enlightening about how much necessary care and many treatment decisions could really fall through the cracks just from the abysmal unknown of it all. But when my dad's prostate cancer recurred in 2018, at that time I was a mom of an infant with another one on the way. And so at that point, it just really became glaringly important for me to proceed with the germline testing, knowing the cancer predisposition risk and implications that I was up against with breast cancer and prostate cancer, and then just other tumor types running rampant throughout my genealogy. I was absolutely certain that I had, or was a carrier of some kind of pathogenic mutation, and initially wanted to kind of wade in the oblivion of it all rather than face the facts. But now through my little ones, my father and I both found our reason and our why to proceed with testing. And so it's just really important for me when I speak to patients who are fearful of starting chemotherapy or proceeding with that biomarker testing or even enrolling in clinical trials to really find that purpose and that why and to just hold steadfast to that and really let that be, your driving force. And so that honestly, that was the scariest thing. But likely the best thing that happened to me career wise or profession wise, because now I'm able to lead with that empathy and that compassionate care, and to lead with the understanding of I've literally been in your shoes or situation as a caretaker. And so, as you mentioned, I do lead our genomic oncology advisory board and have been very instrumental in developing our precision oncology program. But genomic literacy has been the most challenging obstacle to overcome, not only for our providers, but for patients and caregivers as well. So providing them with those advocacy resources to educate them in a very succinct and understandable fashion, something that they can watch on demand or share with their loved ones about, what is genomics, or what is the difference between genetics and genomics. Even some of our providers still ask that question, but what does this testing imply in regard to my health coverage or life insurance coverage or even my job? Like what happens to my data, who owns that, what does that mean? So really equipping them with those tools, that they need to feel empowered as a healthcare team member and an advocate.
Yeah, I mean, the words you're speaking right now, you don't know this, but this is so critical in my mind because just a week ago, my best friend got a devastating breast cancer diagnosis. And yesterday, she told me triple positive, incredibly scary. But today, because of research, we have a path. She has a really difficult path ahead of her. But she has a path, and it's because of research, and we cannot stop thinking about that real intersect between treatment, therapy, and the future, what we can learn from the future, and the genomics and the therapies that we've already brought to market, and are in use still depend on future learnings and discoveries that we'll make. But how do you navigate that conversation? Because when you get that cancer diagnosis, as you know, as I know, probably no one in this world has not been affected by someone they love getting some cancer diagnosis. It's incredibly difficult, understandably so. So, how do you make room for a discussion around participating in research alongside that conversation around the conventional treatment options, we're dealing with today and how we're going to treat your father's prostate cancer, my friend's breast cancer, my mother's lymphoma. But we got to make room for that research discussion. How do you do that? What are some real approaches that work?
Molly, I'm going to be very honest with you. There was a time, and before being in the weeds of clinical practice, that I was very ignorant to the fact that a clinical trial was like the last ditch effort, right? Something that it's really not at all. It's definitely a standard of care in all the guidelines, and it should really be spoken about as an option from the very beginning and all throughout the cancer care continuum. And so, you know, I've had a personal investment with my father and family members, and you, of course, with your best friend. It's getting that cancer diagnosis is undeniably difficult for individuals. And so, to incorporate discussions about participating in studies alongside conventional treatment options, it's absolutely crucial to create an open and a safe environment where patients feel supported, but encouraged to explore all of these available options. So, you really have to change the optics of it all. I find that people seek care, from those that look like them or can intrinsically relate or advocate or be an ally for them. So patients really need to feel comfortable expressing their concerns or possible limitations to proceeding with conventional treatment or a clinical trial.
Yeah, I think that's really important that they feel like they can express the fears they may have, and feel supported. But, we talked earlier about there are a lot of people that likely have a fear, and justified fear, of the health system. And there are a lot of underrepresented groups in not just health, and lacking people who look like them to care for them, but also obviously in research. So I'm interested in how, we as a we as a healthcare community in particular can address some of that mistrust or fear. It may be mistrust, it may be fear, it may be, maybe sometimes it's ignorance, but in underrepresented groups, particularly racial groups, and with language barriers, and even women as opposed to men. what are things that you're using successfully and you see working at Northside?
So I say to address that, underrepresentation of racial minorities in studies, really engaging with community organizations, leveraging the trusted community leaders, and implementing culturally tailored recruitment strategies is essential. Establishing partnerships that may prioritize inclusivity. And I may be a little biased, but as a Howard grad,
Yeah.
but consideration of partnerships with HBCUs, historically Black
Yeah.
colleges and universities, providing education on the benefits of the research and actively listening to community concerns can significantly improve participation rates. We have to understand recognizing the social determinants of health and how that disproportionately creates health disparities in cancer care. So we're talking about redlining or safe housing and transportation, racism, discrimination, violence, the fear of the unknown, but just even educational and language and literacy skills, as you mentioned. But then ageism. So whether it be, the stage of with your academic curriculum at that particular school age, patients learning about DNA and genetics, when did that start about? But then also providers knowing that didactic learning for medical school, nursing school, pharmacy school does not always include a specific course to highlight the importance or clinical utility of pharmacogenomics or precision medicine. I graduated in 2014 and it was an elective for me, so I can definitely guarantee that I did not have that particular course. But knowing that the NIH has identified these particular populations with health disparities, so as you mentioned, racial and ethnic minority groups, but then lower socioeconomic status, so maybe incentivizing the participation in the underserved rural community, so getting out into the community, meeting the patient where they're at. But then most recently, we've seen a lot of light on sexual and gender minority groups, so being extremely particular of verbiage and guidelines to clinical trial protocols that take more so an organ inventory or using gender neutral language rather than a he she approach. That language in clinical trials can exclude transgender patients. So maybe saying men with prostate cancer or women with ovarian cancer wipes out a whole population. So using that trauma informed care resources to really equip health systems and training their providers, training their residents to safely collect and analyze that data, but then to enhance trial recruitment and retention, we need to learn how to address these cultural and logistical barriers to improve the retention and lead to more reliable and robust clinical trial data. So ultimately, patients need to be considered in their entirety to fully feel represented or appropriately cared for.
Yeah, I love a lot of the things you said, and one of the points that you mentioned, which was ageism, which I'm seeing that already in the care that I'm observing my father go through in his 70s, and in a end state renal failure. It seems like many times, and this is something I feel like we have to address in the healthcare and in the research community, not not being willing to entertain some of these research programs because is he too old, or these innovative treatments or therapies because is he too old, is he we're looking for a certain demographic that we want to research on. But you said something just a moment ago about the barriers to research participation. And I was talking to someone who's working on a really interesting study that is going to be going into a specific area, specific city, into barbershops to test men for a certain disease at the barbershop. And it was interesting because the point of the protocol was to get out into the community. Don't make people come to you. You want a certain population going to them. And I thought that was a unique approach. We'll see if it works, but a unique approach to addressing a barrier, which can be transportation or could be availability of the clinic. So I'm interested, that's one of the many barriers. What other barriers do you see being the most difficult to overcome in getting patients to participate in research, particularly cancer research?
I think, the nothing about us without us approach is key, right? And so I think the barriers exist of they don't feel comfortable relaying their issues, whether it be financial issues or childcare issues, with a provider at hand. Like I said before, people seek care in those that look like them or that can highly relate to them. And so that is a huge barrier. But then also looking at the literacy standpoint, like how much do you know about it? I think I'm pretty educated, but up until a certain point, I was very misled about at what stage in time do we initiate a clinical trial. So being more transparent about that, highlighting the clinical significance of a clinical trial and doing genetic or genomic testing, not only for yourself, but for those that come behind you, future generations. It may include, family and friends or people that you don't know it all together, but just being a part of that solution again, right? Making sure that you're moving the needle. And so there are so many barriers, whether it be language barriers. So looking at, informed consents or clinical trial packets that are multiple languages, having interpreters on hand, addressing transportation issues. So whether a transportation voucher, working with Uber or Lyft or whoever, thinking about how can we kind of decentralize this approach and to put it more maybe a hybrid model. So how can we figure out how to get this into the community, into these rural populations or people that are either unwilling or unable to transport to an academic center, as we
Mm-hmm.
would say. Uh, a mobile clinic unit would even help that. Getting meeting the patients ideally, like literally physically where they're at, is a way to address some of those barriers. But it just all depends on having patients involved, having a patient centric approach, having them on patient advisory boards or focus groups to really understand from the very beginning of the clinical trial protocol design what we're up against and how can we have the input from those that are directly involved or will be involved at some point in time of their life in the clinical trial design and how we can help with recruitment strategy. So you mentioned the barbershop, but then even we know in certain cultures, the church is a huge thing. Different advocacy groups, maybe the Y is where, a lot of the kids are raised and you go to these programs and after school care and things of that sort, making it visible and making it less of a stigma that, really these clinical trials are offering better options than what's already on the market, right? But that's so unknown because it's just so unspoken about.
You're right. And it's as if it's spoken about in certain circles, but that doesn't trickle down to the general community at large in a lot of ways. So I think one of the things that I often think about is because we don't, Vibrant rarely does a study where we don't have Spanish versions because we do so many e-consent. We do e-consent for research and we do e-consent videos as well. And it's rare that we see one that doesn't need Spanish, for example. But what I notice is that it's often a question I have to ask: do you want this translated? Okay, is that going to be a part of your protocol? How important is it, do you think, at the point of writing the protocol, even at the point of writing for a grant, if that's what has to happen for a study, or applying for that project to kick off? How important is it to put that thought into the protocol to address the barriers we're talking about?
Ultimately we have to focus on the patient experience and their well-being. Oftentimes we think it's about us and our trial and the drug that we're trying to push to market or the
Exactly.
the outcomes data that we want. We don't want anyone to drop out or anything of that sort, but focusing on the patient experience, putting the patient first and their well-being. So ultimately making it easy for a patient to be involved in the clinical trials. We talked about this nothing about us without us thing, but how can we make it convenient for them? So even if we had a decentralized clinical trial or a hybrid model where maybe the necessary research monitoring parameters can be done via telehealth or someone coming out to the community to do it for them so that they don't have to go to these clinical trial sites. But even again, maybe having an academic or community site, like a primary site, but then having, kind of like a hub and spoke model where it's branching out to other rural areas where they still offer the same clinical trial, but in more rural areas to diversify that demographics of that clinical trial. It's so um, saddening when you look at the patient demographics and you don't really see people that look like you. So it's that whole model of not taking someone else's drug, but essentially, you taking the drug from the clinical trial, you are taking someone else's drug, a drug that was not meant for you, did not really include everything about you. And so to expect the same outcome as what's showed in the clinical trial data is kind of unrealistic a bit if you don't have that comprehensive demographic model.
That's so important today because I think for so long, therapies have come out and they're tailored to white males, and we don't know what that will do to someone with a uterus. We don't know what that could do to someone with a totally different ethnic heritage that has very different genetic makeup or background, or even someone with mixed ancestry, which is I would I would offer probably the majority of Americans have a mixed heritage. Maybe there's quite a few people who don't even know that, but it's critical that we get more of the understanding, but also the acceptance in the community of this is important for our futures and our future generations' health. So, we have a commitment as a community, I think, to incorporate plans and approaches to address underrepresented populations. But I think one of the things that we're not doing a great job, because it's decentralized across all the institutions, all of the research programs across the country, is that education about genomics and the importance of genetic based research, and specifically for therapies, for pharmaceuticals, it's really important. So how can we educate potential participants and address resistance in the general community associated with genetic research? What are things that you see are opportunities that we need to be taking better advantage of as a health research community?
Yeah, I mean, underrepresented groups may view genomics and genetics research with skepticism. Even I can see it with my own family members and friends. And I mean, that's simply, undeniably due to the historical mistrust. You have fears of exploitations and cultural beliefs. And so, really educating potential participants requires culturally sensitive approaches, community involvement in study design, and explaining the potential benefits while also addressing some of the concerns related to privacy or stigmatization and discrimination. Ultimately we need a collaborative approach, and this also includes the patient, but with cross-functional teams. We're looking at clinical operations, like how are we screening the patients, how are we retaining them, how are we analyzing the data to make sure that this is a fair and balanced demographic for the clinical trial. Looking at regulatory affairs, so patient advocacy groups like we spoke about, advisory boards and focus groups, and the community organizations such as the church, such as the barbershops, is absolutely necessary. Representation in the workplace, our research team, is key. As a Black female, I'm a double minority, but I truly believe that my presence and my leadership and my current role can serve as a powerful example of diversity inclusion in the field. I think my unique perspective and experiences can contribute to creating a more inclusive and welcoming environment for them to kind of talk to me about, and to lower their guards, both within the organization, but in the broader clinical trials community. So it's all about just transparency, taking accountability of what went wrong in the past or even going on present day, and reverse engineering that. How can we really get the patient involved? How can we make sure that the people that they're getting care from, or they're trying to recruit them, truly understand what they're up against historically and present day?
Now, Portia, you being there, you having a seat at the forefront is critical. It's critical for women broadly. It's critical for Black women. It's critical for the Black community, but really any little girl who sees you and you're treating their mother, their father, their grandparent, their brother, sees that and sees that their community is very diverse and broadly so, and represented in healthcare. It's a critical piece that I think we have to invest in the future of health. Um, Caregivers, clinicians, researchers, scientists across the entire continuum. We have to invest in the future uh, people in those roles. And I'm interested in, how do we do that, not just individually in our communities, but at scale? And how do we educate at scale? I think digital methods have a lot of promise for us. And I, of course, being a Vibrant, we are a digital technology company. That is what we do. But in the field, in the actual practice of research, where do you see more opportunities emerging for digital methods and digital technologies that either are changing the game or could be changing the game for research
Yeah, I mean, I totally
and
agree. Digital methods,
representation?
yeah, digital methods hold great promise. In informing and engaging patient populations in research, but especially in today's world, digital marketing strategies is huge. You can't go anywhere without something being an app or something of that sort. But utilizing those online platforms, interactive websites where they can speak to a navigator in real time, address their situations or their challenges in real time. Social media, everyone's on TikTok and Instagram and LinkedIn and Facebook, so putting the opportunities on there, or the news or something of that sort, making sure we're including all of the age ranges. Mobile apps that we talk about for to provide accessible information. So whether it be downloading an app where all their genetic or genomic results can be on their phone, so when they're going to their providers, they have it right then and there to be able to share with their providers versus sifting through papers or PDF formats or something of that sort to remember to give to their providers. But reaching broader audiences by virtual participation or providing a platform for patient feedback and engagement. What's working for you, what's not working for you. If you decide to withdraw, because they have a right to withdraw, what is the why, or the why not? And not, don't be pushy about it, but definitely addressing, is there something that's going on, as a recent challenge that we're unaware of that we can kind of help mitigate that will allow you to continue in the clinical trial. We spoke about the patient advocacy videos and resources that I've created for patients and their caregivers to watch in real time and be able to do that. But also thinking about pre-screening software, data warehouse repository for patients' genetic and genomic results to search for those clinical trial eligibilities or newly approved targeted therapies. AI is huge. I use AI. It's increasingly making this more feasible to streamline these processes rather than a manual search. But then on the flip side of that, from an administrative side, assessing the metrics to analyze and strategize quality improvement processes for better feasibility or overall outcome. And then I think most importantly for the patients is regularly reporting on the trial demographics and make that data publicly available to promote that transparency and accountability. That way we're able to mitigate the trust or the mistrust that they have, to be able to be so forthcoming with this information so that they feel comfortable someone else that looks like me or that can relate to me has participated and these are the outcomes. Now I know that it's possible for me too.
That communication part, I think, gets missed in research. And it I bring it up with a lot of our collaborators, and it's something I think the All of Us research program does really well, which is they are very clear about what are we learning, how many people of what, the various demographics. They do all of their materials in Spanish as well. But I think a lot of, especially population genomics research programs, don't think about, and I didn't give you this question to prep for. So um, I'm interested if you have any thoughts off the cuff. How do we get better at thinking about that when we build these, especially the longitudinal, multi-year observational studies, where maybe they're not having a therapeutic, um, protocol that they have to report their reactions or advert or AEs or whatnot. Maybe it's just observational, but there's that critical piece of keeping people as a partner in your research. How do we get better at that as a scientific community, do you think?
I think starting from the very beginning, when you're looking at, before we even start recruiting and things of that sort, when we're really looking at the clinical trial design, having someone, and it's going to take, a special population, a special someone, making sure that the literacy is there, the comfortability is there, and the willingness to help themselves or their community, but having them in the conversations, including them from the very beginning, not when the trial has already been developed, not when we're in the midst of recruiting, but keeping that throughout the continuum of the clinical trial development and the research process, but then even wrapping up and tying the bow very nicely at the end of, this is what your contributions were, and this is how they aided to our development, and these were the results thanks to your input. would make the world of difference of people being willing to donate their time, right? Or are they being incentivized for this help? Either way, whether incentivized or not, it's absolutely critical, absolutely necessary to be beyond the scientists, beyond the research, because you can get so tunnel vision, so myopic that you're not considering other factors that are not textbook, right? That you wouldn't necessarily be privy to had you not had these conversations initially.
Yeah, I love a lot of your points, especially one that just made me remember. We released or published a paper on a study we had collaborated with a few groups in Virginia on a few months back, and one of the indicators we looked at was why people were choosing to participate in research, and overwhelmingly it was altruism. So they want, so to your point about being willing to give their time and give their information, people do care about their communities. They care about their grandmas, they care about their kiddos, they care about their aunties and their uncles and their tios. They care, and they want to um, give, but they only will give for so long if you don't also give to them, which is what you're talking about, is thinking about how do you show them that it was all worth it. Maybe it was only 5 minutes, but maybe it was 3 hours of their time and travel. It was worth it, and this is how it was worth it. So I love what you said. So I just have a couple of other questions for you. One is, I like to ask this question two times because I like to frame it in the short term. And then I want to think big picture, long term, blue sky. What is your vision for the future of cancer research in the next 3 years? Where, especially in genomics powered research for pharmaceuticals and therapies, where do you see that going? And how are we going to get there? What do we need to do to get to that vision you have for the short term?
For sure. I hear a lot of individuals that say that precision medicine or precision oncology is the future. This is where we're going. But in reality, it's where we're at. It's where we've been at. But
Mm,
again, we just don't know how to tap into it, or not all of us are understanding of how to interpret the results and what are the clinical implications. And some of them, have been VUSs or variant of unknown significance for quite some time. And just now are they pathogenic or prognostic or something of that sort. But the future of cancer research, it does lie in these personalized or precision approaches. You can bypass the trial and error and the so-called standard of care that is not really truly meant for you or designed for you, and integrate that genetic and genomic data, whether it be screening, preventative screening measures and the frequency of that, or even, okay, you have a targeted therapy that is now an option for you versus a traditional cytotoxic chemotherapy. But to get there, we have to address these barriers to participation. I would really love, my ultimate goal and dream would be universal biomarker testing for everyone. But with that becomes, the ability to have comprehensive insurance coverage or reimbursement. That's always a thing with providers and patients, of how much is this going to cost me? But I say you have not because you ask not. There are so many organizations that have grant funding or patient assistance to provide coverage for these testing mechanisms, right? They are really truly key to the treatment decision, the informed treatment care. So really looking at that standpoint, again, reiterating community-based research or mobile clinic setups to heighten the accessibility of these trials within the community setting, to really broaden our ability to reach diverse populations. We know that patients' inability or unwillingness to travel leads to those missed opportunities for trial accruals or screening. But if we can really get that away from in-house academic centers and move that to community-based research and remove that stigma of I can only get it at this major academic center or it's no good. Um, Understanding that there are just as good, if not great or greater, providers in the community setting because they want to help their community. They want to be those, servant leaders for the people that they know are disproportionately disadvantaged. So dispelling that stigma altogether, and really offering a clinical trial at every single point of the cancer care continuum would be ideal for me. And that would be my ultimate goal.
I'm starting to see little, because we, as I mentioned, we collaborate with quite a few groups out there, including cancer centers. And I'm starting to see this approach to, you know, building e-consent for research into the clinical intake. So there could be in the short term various, and I'm sure you're working towards it there at Northside, short term real movement there. But now I want to ask that question again and think, 10 years, where will we be? Because Dr. Johnson, you will be at the very forefront and you will be driving us. And where will we be in 10 years? Where will cancer research be in 2033?
Yeah, I think that is all up to our policymakers, to be honest. Whether it
No,
be,
just kidding.
I know, but we have to be vocal and we have to educate and we have to have those peer to peer conversations, because a lot of times you'll see, even when we're trying to combat prior authorizations or insurance denials for off label therapy, they are strictly going off of black and white guidelines, and their oncology is such a great area, and you have to really understand the nuances of it, and it's a if and or but and then this type of thing. It's not a straight path, a linear path at all. So if we're able to collaborate with those policymakers, where we do have that insurance coverage, we do have that reimbursement, we do have that comprehensive healthcare package that includes universal biomarker testing, this will not be an issue for me. And like you said, in 10 years from now, everyone will have germline testing, everyone will have genomic testing. If you have cancer or something of that sort, this will be within every EMR system. So whether you're inputting the order, verifying the order, processing the order, this will be a part of your treatment decision, whether you like it or not. It will be normalized, right? It will be normalized, because you're ultimately, when you're integrating this fully, you're giving the patient the best shot, whether it be cardiology or pain meds or oncology. It is genomics, genetics is something that is so integral, and you cannot unsee it. And so that would be my vision for in 10 years.
I love it. And I feel like that might be the title of this podcast. When you see the genetic, when you see a patient's genetic background, you can't unsee it. And that becomes part of the story. But in seriousness, I don't think anyone could have said it better than you. I greatly admire you and your perspectives. And I'm just so glad you joined me for this discussion today. I can't wait to see what you achieve at Northside. I also can't wait to see what you achieve generally and broadly in the community. But thank you again, Porscha, for joining me today. Thanks so much for listening to the People of Precision Health podcast. To join us next time, subscribe wherever you get your podcasts. And to learn more about how we're helping to engage the humans behind the data, visit vibranthealth.com.